Welcome everyone to the May 2019 SCR CONNECTions webinar and happy Healthy Vision Month. We're so pleased today to have our guest speaker Iliana Molina join us for today's session. Iliana is the director of the UC San Diego and UC Irvine EyeMobile for Children. It's the mission of EyeMobile to work with young children to ensure they have vision health necessary to be successful in school and in life. Iliana also serves as the clinical trial coordinator for UCSD Shirley Eye Institute and also in the past served as a site coordinator for age-related eye disease macular degeneration research study. Iliana started her work with the EyeMobile in 2003 as an intern and has since been responsible for securing funding for the sustainability of the program. Her mission is the same, to ensure all children in Southern California have access to high-quality eye care regardless of barriers. In 2015, she was asked to join UC Irvine as the director of the UC Irvine EyeMobile and bring her knowledge and experience to Orange County. Each year, her team screens over 20,000 children, delivering comprehensive exams for over 3,000 children, and provides over 1,000 prescription glasses to children who need them to see clearly. Iliana received a BA in Political Science and a BA in Human Development from UC San Diego and has also completed her MBA. She's currently working to finish her doctorate in Healthcare Administration from the University of Phoenix. In 2016, she received the Breaking Away Award of Excellence, and in 2018, the Public Healthcare Champion Award from the County of San Diego Board of Supervisors, and was also elected to the Child Care and Development Planning Council for San Diego County. Iliana has presented at APHA for the last 5 years and has been published in numerous journals. We are so happy to have her with us today. Good morning, Iliana.
Good morning, everyone, and thank you so much for being here today. As I was telling Sarah, I really hope that we can all pull together. I've been having a cold for this last week, so if my voice breaks, I will drink lots and lots of water. But definitely. Hello, making sure I'm still on here.
I can hear you, Iliana. Thank you.
Perfect. Okay. So we're going to start today with a presentation, Eye Health Across a Lifespan. And Debbie approached me when we were doing this amazing work with APHA when they were here in San Diego, and we did a presentation. This is a full, it was a half-day presentation out here where we were able to meet with different individuals from tons of different backgrounds. There's about 80 of them, and we condensed it all, and we're going to try to cover as much as we can in this next 45-minute span. So we will cover everything from birth till when we get old, and everything that comes between. Again, as Sarah has mentioned, any questions, please just type them up and let me know as I'm covering that topic, because I will forget. So starting off, so the biggest thing is when we're born, the longer we stay in the tummy, the better. Children who are born premature, which is technically anything before the 37th week of pregnancy, suffer from what we call ROP, which is a retinopathy of prematurity. Here at UCSD, we're very fortunate to have one of the leading doctors in ensuring that these children can definitely preserve whatever vision they have and definitely prevent the loss. So what ends up happening is these children sometimes have to get laser surgery to definitely keep the macula from falling off. Basically what ends up happening is it's so premature that it's still not completely staying in the eye to preserve the vision that it can have. Yearly, we have about 14,000 infants who are affected by ROP. And the hard part is knowing that about 400 to 600 of them become legally blind. So this is definitely something that we watch right from birth. So as you can see by these pictures right here, the laser, what it does, it definitely keeps this part from falling off, this detachment. Again, the biggest thing is catching it, and most NICUs are followed closely by either Department of Ophthalmology universities or leaders that can definitely work closely with families to ensure that after a week, 2 weeks, 6 months, the child doesn't lose any more potential vision. When a child, that picture is kind of funny, when the child is full term, you can definitely see that when they start opening their eyes, the biggest thing is that they have really poor eye movement. Sometimes what we call strabismus, the eyes go in different directions. This is completely normal until the age of 6 months. The children at birth and those 6 months do not perceive color. So this pink and blues and all that kind of stuff don't happen. What they see is a black, a white, and different shades of gray. The biggest thing is that they are interested in faces because that's nice and close. So when we talk about, visual acuity, the refractive error, at this age, these little ones are only seeing anywhere between 2400 and 2800. So very, very poor distance vision. This right here shows different milestones. Again, anything after 6 months when those eyes are still not converging or moving well is when we will start asking for referrals. But anything before those 6 months is okay. This is my mission. So the common eye problems in kids are what we call amblyopia and strabismus. These crossed eyes, anytime after 6 months, we definitely have to be careful because if we can put glasses on these little ones and fix the alignment of the eye, the better outcome it will have. If we diagnose and find a child after the age of 9, it is very difficult. And this comes from amblyopia, from the lazy eye. So this is when one eye is working better than the other. And when the other eye doesn't work, it becomes lazy and starts to verge off. This right here is an illustration of how refractive error works for children who have normal vision as opposed to those who are hyperopic, myopic, and then for those children who have astigmatism. Most of you guys know, you can't see near, you can't see far. The biggest or the nuance that we have found is that many children, especially here in Southern California, have a combination of both being farsighted and nearsighted and having astigmatism. Astigmatism is something that happens when your cornea is not a perfect circle, but rather kind of oval. Almost think of it as a football shape. So you can see the difference of how the vision is. So it's a little bit more distorted, thus why the need for glasses to see clearly. Again, here it is at birth, the percentages. The biggest thing here is that premature infants are up to 45% myopic. I kind of covered a little bit about amblyopia and the lazy eye. It is not this huge number-wise, but for those children who have it, it is huge. It impacts their life. So overall, national statistics put it at about 2% of children. So strabismus, again, the misalignment of the eyes, anisometropia, which is telling us that they can have astigmatism, hyperopia, myopia, and esemetropia, which is the astigmatism, hyperopia, and myopia. So what this means is that it's an unequal refractive error. So the way that the children's eyes are go in or out. The biggest thing, as I told you, early detection is key. When you see children, as that little boy on the bottom with the blue polo, what they're doing right there is they're patching the good eye. What they want to do is promote what we call the lazy eye to start working. When we start patching, it could be anywhere from 2 hours, 3 hours, to full 8-hour days. The research has told us that even patching for some length of time is better than nothing. So when we see these little ones, we urge parents, because it is very difficult for a child to patch the eye that they've been completely dependent on their entire life, and get now the world from an eye that is compromised and is not working the way it should. We always start amblyopia with glasses. This can be picked up by optometrists, and then what optometrists do regularly is, because the type of follow-up that they will need should be then followed by the pediatric ophthalmologist, and we'll cover those in a little bit. This picture demonstrates a little one with strabismus, which is the cross-eyed. They're not looking at you at the same place. In some children, it does cause double vision, but more importantly, it leads to amblyopia if it's not picked up. So again, any little one that you see after the age of 6 months, if you see this, definitely it brings in some concern. And this is when we want to make sure that they start seeing an optometrist, not a pediatrician, but an optometrist or a pediatric ophthalmologist. A little bit more of strabismus. You can definitely read on the treatment that we have on crossed eyes. The last, again, very successful way to deal with crossed eyes is eye muscle surgery. It's a type of alignment surgery where they go in and they cut muscles. So behind the eye, the muscles that lead to how the eye actually moves are the ones that are cut based on the type of strabismus that the child has. So, as I told you right now, from the surgery, as you can tell right here, these are the muscles that would be cut. The critical period, birth to 7-8 years. Again, as I told you, anytime anything is picked up later, it doesn't have the same percentage of it recovering as well. This right here is the end-all be-all. If you can see here that 1 in 10 children has a vision problem that is significant enough to impact learning, this is why we do what we do. This is something that doesn't hurt. It's not like a cavity, and it's not something that you can see. These little ones are in those preschool classrooms, are sitting in the classrooms in those desks, trying to do the best they can. It is really important that we understand how imperative it is to find these little ones, especially before we start bombarding them with reading and all that kind of stuff. You know, so many doctors are focused on speech because it's something you can hear, but many of our pediatricians still lack a lot of education, as they only get about, I think the last survey from our medical graduating class here from UCSD, I think they received a total of 8 hours of total eye disease. So they definitely got a different version of how important it is to screen for these kinds of issues. The biggest thing is vision and reading. We have discovered that if we cannot make reading fun and attractive, how are they supposed to learn it when they can't see? We have been fortunate here in our department to publish amazing research that shows that if we can find these little ones and put glasses on them, within 6 months, they're at their counterpart level, and some even exceed it because they can catch up. Children have an ability to accommodate like no other, and this ability allows them kind of just to persevere with whatever vision they have. But it's funny because accommodation is high when you're a child. As you get older, you know, when you're trying to squint either to see that menu or to see that sign when you're driving, our ability to accommodate decreases, but these little ones have an amazing ability to do it. The problem is that they can't do it all the time. Reading proficiency in high school graduation, increased risk of falling behind. I mean, statistically, these kids are 4 times more likely not to receive a high school diploma. So there has to be an investment in these kids and ensuring that these kids can see, as it has implications for the rest of their life and their success in school, ultimately. So the pediatric eye exam, as of right now, I can only speak for the state of California, but we do not have any sort of legislation or mandate for a pediatric eye exam. Right now, we have, as in most states, they have screening. The screening is another one that's also difficult to mandate, but if you know, when you go take your kids or when you do a distance eye test, they have a different visual acuity, you know, when the E is on the top and it's a whole chart on the wall. What we have found is that children, especially those with astigmatism, are able to fake their way and kind of squint their way down. The kids can't hold it. But ultimately, children before the age of 7 are hyperopic. And it is only when they are 8, 9, and 10 that their vision becomes myopic. And that's when they begin to say, hey, I can't see the board. But before that, these little ones can't see up close. So we see the difference when you put glasses on a little one, when they're coloring and they can stay in the line, when they're practicing their name and they can actually do the tracing correctly. It really is because they couldn't see. So as part of a eye exam, this is the information that we definitely want to collect as much of it as possible. Right now, states have mandates that only require visual acuity, and that's just not enough. This statement is one that we live by, that the number of preschool children with visual impairment is projected to increase by 26% in 2060, with 69% of visual impairment resulting from simple uncorrected refractive error. Hispanic white children will account for the largest number and proportion of cases, followed by African American children. And this has nothing to do with socioeconomic. It really is a difficult impairment because, again, it doesn't hurt and it doesn't affect only the poor or the rich. It affects children. So here it is, myopia on the rise. As of right now, we have statistics that are able to provide to us that roughly about 40% of Americans have myopia, which is a 25% increase since 1971. The reasons for this developing is the genetics. The theory here is that there is more exposure to natural light, which leads to the release of dopamine. So it translates to the less eyeball elongation. So anytime you have these high degrees of myopia, it translates to diseases later in life, as in retinal detachment, and then glaucoma and cataracts when we're elderly. Myopia control in children. We have different ways to treat it. One of them is a soft contact lens, the drops, multifocal eyeglasses, and undercorrection. This will vary state to state, or rather provider by provider. When we have little ones and we sometimes lend them our phones and all that kind of stuff, it definitely translates to now having a different incidence of things we're seeing. So before, children would be playing outside and all that kind of stuff, but now people, including children, are reporting that they're spending more than 2 hours a day on a digital device. So when we have this kind of new apparatus and stuff, we're going to start seeing new statistics, including eye strains, and then the blue light, which is released by these apparatus. But we're definitely seeing, that teens and children are developing differently than they were before. Any questions? I want to make sure everyone's still okay and all is good. 65% of Americans. Yes.
There's one question in the chat box asking, will a typical vision screening, apparently the chart covered the question. The question was, would a typical vision screening examine visual fixation, tracking, convergence, and accommodation? But looks like your chart covered that, so.
Okay, perfect. Thank you. So yes, so more importantly is when we're dealing with little ones, we don't want them to go to the pediatrician. Pediatrician is not the eye doctor. We want to make sure that they get followed up by an optometrist or a pediatric ophthalmologist. And speaking now on digital eye strain and computer vision syndrome, we are all guilty of this. When we have those dry eyes or the eye strain, kind of the headaches, the blurred vision, we are spending too much time on these digital devices. What we need to do is ensure that we are, have the right prescription, if that is what we need, ensure that the lighting is there, that we have the right monitor and display. More importantly, it's the 20-20-20 to prevent this digital eye strain. Everybody works differently and everybody's threshold is different, but again, yearly dilated eye exam is what I recommend to anyone over the age of 18 when, if you remember, when you go into college, your prescription can change by almost 2 diopters in that 4-year period by the time you are done because of the amount of you reading and all that. Now imagine we were just doing it by books a billion years ago when I was in college. Now the kids are on these devices. So that's why it's even more important to ensure that we have what we need. I just saw the question, you're concerned about the blue light, especially at night. Most of us should stop working on any sort of blue light device within 2 hours of when we attempt to go to bed. The problem is that it is affecting our ability to sleep. It is very important that if we cannot do that, because sometimes, you have to stay up late and finish what you have to do, that then you have exactly what it tells you here on the proper lighting, the glare, the type of monitor that we have, how ergonomical the equipment that we are using is. More importantly, as my optometrist told me, you have to put it away. It keeps you up, and then you can't sleep as well. And then you're not going to function the next day. So pick your poison is what she told me. So here's a little bit more about this blue light and how it affects it. Computer glasses do exist. I'm sorry, I just jumped because there was a question. Computer glasses do exist, and some of them are just, there's a trifocal and a bifocal. Some people cannot use them, at which point you should have designated glasses just for computer. They have a new lens that has been developed that have screenings to protect your eyes. When you are out and about, you can see when individuals have this, when there is a purplish tint to the glasses. That means that they have a tint to protect them from the computer released colors. So you can definitely get computer glasses. More importantly, if you're going to get them with your specific prescription. Don't get them over the counter. Don't buy them online. Go to your doctor, get them specifically made for you and with the filter that's going to help you best. Going back to the slides here, the blue light, short wavelength, and high energy sources. These are when it becomes a harmful light as opposed to the less harmful, but nonetheless still harmful. The reason we call them harmful is because at the end there could be damage to the retinal cells, which lead to AMD. We will get to AMD. It's age-related macular degeneration. But the benefit of making sure that you have the filters is that the benefits for the benefit of the 480 that you saw on the slide before is that there is an effect on the circadian rhythm, which decreases the melatonin, which leads to us being more awake. So now remember when I told you to put those devices away before you're going to bed? This is why, because we are more awake with this type of light. The preventative treatments, again, sunglasses all the time, anytime you are outside, even if it is to just go get coffee, sunglasses with a broad spectrum UV protection. This will hopefully, in most cases, decrease your chances of developing cataracts. Again, no digital devices 2 hours before our bedtime. The glasses, the blue blocking glasses, like I discussed and addressed for that question. And there are some adjustments that you can do to screens that are newer. I have an old screen, and my IT kindly told me that I was not able to make those adjustments because it did not have that ability. So you have to have a newer model of screen or monitor. So what happens after you're a kid and you go to college and things starts changing? We call it presbyopia. It's usually after the age of 40. I wish I could tell you that there's signs. What ends up happening is basically from one day to the other, you're just like, whoa, what happened? It changes. Our eyes continue to change. You start, those menus you start pulling them away a little bit more. And the only thing I can tell you is that it's going to happen if it hasn't happened already. But more importantly is that the industry has developed tons of great resources, and ultimately that will enhance our getting older. We now have contact lenses that are bifocal. So again, no one has to know that you're even wearing that bifocal. And by bifocal, I mean those glasses with the line in the middle. You know, one's for distance and the other one's for near. Now, if you have glasses and you're working on the computer, you have a trifocal lens, and now they have it where they don't even have those lines for you. So you have a distance, one to use when you're on the computer, and then one to use when you are reading. And again, if you want nobody to know, we do have multifocal contact lenses. And LASIK is, of course, an option. LASIK, again, is only done when the prescription stops changing. So definitely it'd be post-college, I'd say anywhere between the age of 24, 25, 26, when it kind of is able to stay. If you do it too soon, what is going to end up happening is you're going to need to do it again. Dry eyes. We've heard about it. Some of us have suffered from it. Over-the-counter tears are usually the first go-to. It is really important that we also know that when we have dry eyes, unless medically indicated, you use things like artificial tears. Not to throw any brands or anything under the bus, but a lot of them say, like, reduces the red. What that basically means is it'll stop the vein, it'll compress the vein, and that's not what we want. You want artificial tears so that it'll keep your eye not dry, but more importantly, not constrict those veins. As we age, these are some of the most common eye diseases: AMD, which is the age-related macular degeneration, cataracts, glaucoma, and then for individuals who suffer from diabetes, it would be diabetic retinopathy. 1 in 28 Americans over the age of 40 is affected by low vision, or in some cases, blindness. A lot of these things that we have here are diseases that are brought upon by the way we live our life. And as we go on, I'll be able to tell you here. So our eye, these are great images of the cross-section. So if you can see here, the cataract is that film that grows right in front of it, right there. When you see the retina, and these are the diseases here, AMD, as you can tell right there, optic nerve glaucoma, that's when we have the eye pressure issue. And then for those who have diabetes, the diabetic retinopathy are all there. That just kind of tells you where the part of the eye it is. Biggest thing, AMD. I was fortunate enough to work on the eye-related ARIDS 2 study, where we were working to find out how the progression was affected by different sets of vitamins. The NIH did a wonderful job, and now we have, for those individuals who have family members or, there's a genetic linkage to AMD, that they can purchase over the counter. More importantly, AMD, what it does, it takes away your central vision. There are 2 types of AMD, which is the wet and the dry. And one of the leading reasons why people get AMD is because of smoking. So remember how I just mentioned central vision? This picture is of 2 kids holding 2 balls. You can't see the kids' faces, and that's what happens. Smoking, again, here, doubles the risk, and that includes secondhand smoke. And that's something that all of these diseases that I covered, the 4 diseases that I told you about, smoking has that same factor in all of them. So not only our lungs, but also our eyes. I'm gonna go a little bit fast in the interest of time. I apologize. What are the symptoms of dry eyes? Itchiness, redness. Anytime you know that things are different. More importantly, if you have your yearly eye exam, your doctor will be able to see pink macula, and I'm sorry, it's the damage that we get from the sun from not kind of wearing sunglasses. It also increases. So this is also something that your doctor can see. But more importantly, it's that itchiness, it's the redness, the inflammation that would bother you, and that's how you would know it's dry eye. Getting back to AMD, the dry is in about 90%. Wet is 10%. Unfortunately, when we're talking about wet cases, most central vision at this point is completely gone. We try to keep it in the dry for as long as possible, and that includes injections to the eyes. But we aren't always successful. This is an Amblyopia grid. So when you see this, you'll kind of know that patients of yours or family members, their doctor has recommended for them to follow up. So what this patient would do is look at this grid and see the middle of it. A person with AMD would see the grid as to the right. You see how it's kind of irregular. It's no longer the straight lines. And that's how we would detect if the macular degeneration is getting worse or not. These are the treatments for later AMD. Moving on to cataracts. Cataracts are one of those things that the risk factor here is sunlight exposure. So this is why it is so important to be wearing sunglasses when you're driving, when you're out and about, walking the dog, whatever it is that you're doing. It is a quick fix in the sense that cataract surgery has become very common, but nonetheless, it's still invasive. These are some of the symptoms. The blurry vision, the yellowy browning of the vision, the glare, and again, we can go in and it removes that extra film. There is a lot of work in India, and it's fascinating to read how easy it is to give back individuals their life, because cataracts make you, in some cases, go blind and you can't see, and it is because of this film that's grown over the eye. Once it is removed, these individuals can go back to normal. Again, I can't tell you enough how important it is to wear sunglasses now. I am not telling you to go out and buy the Prada and the Gucci, although sometimes they look the best. But what you have to look for is that they are UV protected and that they will keep away 100% of that blockage. Diabetic retinopathy. Again, this is for individuals who have diabetes. So more importantly, in some cases it does lead to blindness. And gestational diabetes for those women who do have it while they are pregnant, it is also important to get that follow-up, because the damage of the eye can still be done during that short term, even if it is while they're only pregnant. You could see the difference of what it is, a normal retina to your right, as opposed to all these blood vessels that have, lack of a better word, popped. And you have these aneurysms of these vessels all over the retina. Again, the normal, and then those with DR. In cases like this, injections of the eyes and laser treatments are what we do. The most important thing for diabetic retinopathy is for those patients with diabetes to monitor their sugars. The less highs and lows, those extreme highs and lows of sugar glucose levels, the better. Ultimately, the detection and the treatment, we can almost ensure that they will not go blind. And the last one that I definitely want to touch on is glaucoma. Glaucoma, the best way that I could describe it is just as we have blood pressure. The eye has its own pressure. And when the pressures of the eyes are either too high or too low, we call that glaucoma. When they are not regulated, they can cause blindness, especially in the elderly. It's very true. Glaucoma doesn't hurt. In most cases, there are no symptoms, especially for that primary open-angle glaucoma. I've been very fortunate in working here at UC San Diego that I even work with our Padres baseball team. And these are great, healthy young men who are out on the field, you know, wearing their sunglasses after I've given them my spiel. But when we do that initial eye exam, many of them have risk factors. And we as providers know that perhaps this person has a higher incidence of glaucoma. And you just don't know. But when you're able to look at the numbers for the eye pressure, that's when we know and we get alerted. For those of you who have had the eye exam, you know, when you put the chin inside of the machine, that kind of blows a little puff in your eye. That's what we're doing. We're measuring eye pressure. So that's the indicator of glaucoma. 2.7 million people in the U.S. have glaucoma. Hard part here is that 50% of them know, and the other 50 do not. Who's at higher risk? African American. I can tell you, working here in the clinic, that African American individuals who come in glaucoma usually come at a later state because they did not know. So it is imperative that we get those yearly eye exams. If anything you've learned from today, remember, go get those dilated eye exams. Your insurance covers it. You can get them at Walmart. You can get them at Costco as long as it's by a licensed optometrist or ophthalmologist, and that you get dilation. Dilation allows the doctor to see behind the eye, so we can definitely see the retina and the macula. It is a little bit more expensive, but it is more of a thorough exam. In the interest of time, and of course you guys have copies of this PowerPoint, and if you have any questions, not only can you contact Sarah, but the last slide has all of my contact information. Cataracts, I was told that extreme nearsighted risk factor. Does that sound right? Medicare may not cover basic eye exam. Okay, so Medicare covers downstairs in our clinic 1 every 2 years. So it should cover your Medicare after, you know, when you're after 65. The problem is, though, it may not cover the dilation. So that is something that the patient may have to cover. Medi-Cal, here in the state of California, it's 1 every 2 years, glasses every 2 years. So definitely check, again, what the type of insurance you have and all that. But if your insurance does not provide it, please, you know, set aside that money so that every year you're able to see a specialist, because at the end of the day, you're going to prevent something that can affect the way you lead those, you know, fun last years of life and at retirement. Here is 65 years. Every year, 18 to 64, at least every 2 before first grade, 6 to 18 years. What I also want to recommend is that you don't go to the drugstores and just pick up those glasses, you know, to see better, you know, for the menu and that kind of stuff. The readers that they call that you just have in your purse or in your wallet. You can do that only after your doctor has said that you have the prescription that will allow you to do that. Again, when you have astigmatism and things like that, those do nothing for you. But only after you've gotten the advice from a doctor that you can pick those up to see, then that is fine. There's some people who just have myopia or just hyperopia. There you go. Medicare does cover your eye exam if you go to the ophthalmologist in Delaware. Most states do. Thank you for that. Best way to prevent vision loss, pediatric exams. Those little ones need to get those exams, routine eye exam, healthy eating habits, the weight, especially if you have diabetes, making sure you're regulating those sugars. But the two easiest, and I don't want to say easiest because you can just do it, because I know trying to maintain a healthy weight or anything like that is difficult. But what we know is that smoking, it has a horrible detrimental effect in our eyes. So and that includes secondhand smoke. So if someone's smoking at home or in the office or anything like that, it's really important that we really work on that. The blood vessels in the eyes get affected, and that's what leads to a lot of vision loss and ultimately sunglasses. Protecting ourselves from the glare of the sun is really important. It affects us. It gives us cataracts. But you know what? It gives us a good reason to wear those nice sunglasses. The supplements that can help to labor it. And yes, so if you go online, NIH, there are vitamins that were found to lead to better, apologies, to deal with folks who are before you get AMD and are at that risk level. I'll be happy to provide them to you. I can't think of them right now. It has a predecessor, I believe, but it has NIH logo, not logo, it has the AMD logo on it. So I will get that information to you. Okay. Okay, last here, optician versus optometrist versus ophthalmologist. An optician is that wonderful person that sits and walks with you to find those great glasses that are going to fit best for your face. They make sure that they're sitting correctly, that the line for the bifocal is right where it needs to be. An optometrist is someone who has spent 4 years going to optometry school and are great at ensuring we're wearing the right prescription. An ophthalmologist is a person who has not only gone through the college, gone through med school, gone through residency, but then has specialized. These are the folks that can do surgery. These are ophthalmologists that prescribe. There you go. Preservation is one that the OTC supplement optometrists. Yes. Thank you, Marilyn. Again, apologies, an ophthalmologist. So an ophthalmologist does the surgeries and is able to do that kind of long-term follow-up. Optometrists, again, are great to ensure that we're wearing the right prescription. An optician is making sure that we're wearing the right glasses, that it's the right fit, that the lines are right where they have to be. Okay, a little bit more here. You know, pediatricians are great, but for the colds and the broken bones, when it comes to eyes, a lot of them, their medical assistants are the ones that do the eye charts. So they're not the best for detecting children who need to be wearing those glasses. Different resources. This is my program. Again, at the end, this is my information. This is my direct email. Any questions you may have, please feel free, and I will get you that information for the AMD supplements. Sarah?
Yes, does anyone else have any other questions for Iliana before we move to final housekeeping? One person would like to go back to the resource page.
Oh, of course. The low vision one. I went one too far.
And again, these are in the PowerPoint slides if you were able to download those. All right, so I think we've given people enough time to type out any questions. So it looks like we don't have...
Oh, I'm so sorry. Just to get back to you, it's called the ARIDS-2 formula. So it's the age-related eye disease study 2. It's pressure vision. It's by Bosch and Lomb. And those are the ones that ARIDS-2 has formally put out because that's the one that we used in the investigation.
Great. Thank you, Iliana. And I know Iliana has already mentioned her email is in the slides, so if anyone does think of any questions, you can feel free to contact her later. We'll let you go ahead and get some rest. After this, I will send out the link for the PowerPoint slides again in the chat box in just a moment. And then the name of the supplement, Iliana, is there any way you could type that out in the chat box?
You know what? There is AREDS-2 formula. It is by BAU. Okay, it's by Bosch and Lomb, and it's sold at any of the drugstores.
Wonderful. All right, I'm going to go ahead and stop the recording now and move on to final housekeeping. But first, I want to give another huge thank you. Thank you so much, Iliana, for being here and presenting in spite of being a little sick. So hopefully you'll feel better very soon.
Thank you so much, everyone. And thank you, Sarah.
All right, I'm going to go ahead and stop the recording now and move into some of our final housekeeping.
Perfect.